we're going to discuss the anterior knee and the quadriceps and patella tendon. So, to start, the quadriceps tendon is a common tendon, quite often has 3 layers. So, we're going to start up, we're going to find our quadriceps muscle. So, we have our rec fem muscle in the middle, vastus medialis, vastus lateralis, and vastus intermedialis. So, if we follow this down, we'll see our rec fem form its tendon. And if we follow that down, we'll see that rec fem tendon sitting over the top. Our vastus lateralis and medialis will form a common tendon underneath, and our intermedialis will be our lower one. So we can see those 3 layers there, and they will come all the way down and come onto our patella. So our patella is a sesamoid bone, and we'll see some of those fibres of our rec fem continuing up and over the patella to continue on as our patella tendon or infrapatellar tendon. So our quadriceps tendon, it's not an uncommon area to have tendinosis. So we like to scan, it's quite a broad attachment, so I want to be able to assess all the way out laterally and all the way medially. I want to assess that in transverse and longitudinal. So we can see those 3 layers. Just below is our quadriceps fat pad and prefemoral fat pad sitting down deep there, and we can just see a little bit of joint fluid sitting in our suprapatellar pouch. So as we continue down over our patella, we can see that continuation of the tendon, and then we come down and we're into our patella tendon. So at our proximal end is where we commonly see our jumper's knee, and as you can see, our patient has a little bit of hypoechoic change to that deep portion of the proximal patella tendon. If we show that in transverse, we can see it's just mainly that central deep portion of the tendon, and we get that classic bullseye sign. So this is just some really early tendinopathy, early jumper's knee. But we'll follow that down and through. We can see another broad tendon with broad attachment all the way down onto the tibial tuberosity there. So really nice, back open to long. We can assess for any irregularity. This is obviously in our children with our Osgood slasher. We will assess for that, comparing it to the other side. If we come back up, and we can see our Kager's fat pad sitting deep. So when we see these jumpers knee, we're occasionally asked to inject. I like to come from a lateral approach, so we'll have it in short axis, patella, just coming off, so we've got that tendon change in view. And as you can see on the side there, we're at about 7 to 8 mils down. So we just want to start below and just have our insertion, and we want to just go underneath that patella and just strip away that fat pad from the patella, that highly innervated fat pad. Just strip that away from our patella tendon. Other intervention we might want to do is we will sometimes be asked to inject the knee joint. So the suprapatellar pouch is an excellent spot to inject the knee joint, just under the quadriceps, especially when there's a large joint effusion. Our patient here only has just a very small amount of joint fluid sitting over our femoral hyaline cartilage there. So that limits our window here, but we would, again, we can see that that is just over 1 centimetre down. I want to just move my injection down a little and just slide in over that hyaline cartilage into that fluid that we can see there. Another option, if we're limited with our amount of fluid there, is to come down so we can see our patella and femur, and again just falling into that little V shape left there. And what we want to feel is just a lack of pressure. We don't want to see the injectate pulling, we want to know it's running away. So as we're pushing our plunger, the fluid is running away, and that's our anterior knee.